I am going to very briefly introduce my colleague and I would say friend, Dr. Niranjan Karnik. He's been here about 2.5 months as a visiting professor from Rush University, and it's an opportunity for him to come and bring his many and varied skills, but also to advance some of the collaborative work that we've been partnering on for some time now, and he's going to share with you today. Just a little bit about Dr. Karnik. He has studied anthropology and has a PhD in sociology as well as an MD. He's a child and adolescent psychiatrist. Welcome, everybody. He did his residency and child fellowship at Stanford University and went on to do a fellowship in medical ethics at the University of Chicago. And I have, as I said, I was introduced to him by Norwita Milburn, who had been collaborating with him around youth homeless work. And this was, I think, almost 10 years ago.
Probably more than that.
Aging us. And I have to say, I think he brings a very unique set of skills in academic psychiatry. I think his career has been marked by both generosity and generativity. He has 5 times won the Outstanding Mentor Award from the American Academy of Child and Adolescent Psychiatry, but also a number of teaching and mentorship awards from other areas. He also builds teams that I think are very mission driven. He has a way of understanding and articulating a vision in ways that people can follow and also that elevate and empower the people who work around them. And I think that's been very impressive to me and a model for all of us. He's also a great research collaborator in terms of building approaches in schools, in layperson care delivery and military and veteran families. I was looking over his CV. He's published across a broad array of topics, but really what strikes me is they're all about underserved populations, about health disparities, whether it's immigrant kids, kids in the juvenile justice system, military and veteran populations and their families. And I think it's just very impressive, the intersectionality of what he's been able to bring to the questions he's asking and the kinds of solutions that we've been working on. In particular, thinking about how we expand access to high quality behavioral health care in a country where we know there is shortage and there are not enough healthcare professionals to go around. So how do we teach lay providers to do the pieces of what we do in a way that creates a population level approach to well-being? I think that's it. I'm going to welcome you.
Thank you. Thanks, Tricia. So it's been a really wonderful visit. I'm very sad that it's coming to an end this week, and I'm going to go back to Chicago shortly. Hopefully the winter has passed while I've been here in Los Angeles. But I will say that Tricia and the Nathanson Center and the Center of Excellence have been amazing hosts, and it has really been lovely to meet a lot of the faculty and the trainees, and to be thinking with the trainees about their projects, that we're going to pursue in the near future. I also want to say that, I've been coming back and forth to Los Angeles actually since I first interviewed here as a resident. I did not come here. I went to Stanford, but I have maintained, I feel like, a connection to this place. And I want to credit Peter, acknowledging this transition that's happened. Peter really, from my perspective, and I had a brief chance to talk to him about it, how he engendered this, really included the social sciences in this department in a way that I think almost no other department in the country has done. And to me, as a social scientist physician, that really speaks to the breadth of this institution. And I think that's why I keep coming back here, is because it feels very much like a home away from home for me. And as I am now in a leadership position at Rush, I'm trying to actually build a similar type of institution there, modeled in large part on this place. I even thieved from Tricia, the name of my division in population behavioral health. My has now changed it to community behavioral health, as you'll see for obvious reasons. But we initially stole the inspiration from her. We took focus from here and brought it to Chicago. So we do a lot of thieving from all of you, and I thank you for your generosity in letting us steal. Let's get started. These are my conflicts. I'm a well-conflicted individual, and so I'm fortunate to be able to do a lot of this work with both federal, state, and foundation funding. And the university also provides substantial support for what we are doing now and what we're about to do. This shouldn't surprise any of you. This is one rendition of the mental health gap that this country faces. So what you see here is, any mental illness in the past year broken down by race and ethnicity. And then over here you see that how it breaks down in terms of the various groups who have a mental illness getting access to care. So you can see that some groups do much worse than others in terms of getting access to care, but no one is doing great. No one is even crossing that half of the people who need care are getting care, right? So this is just overall broad numbers, right? So this is what we're up against. I'm going to dig a little bit deeper into the child psychiatry space just because I am a little biased towards child psychiatry, and I feel like we've got the whole department here, so why not go a little bit into our area and make you aware of what's going on. But the lesson is the same that I'm going to show you, regardless of any subfield of the mental health landscape you look at. What I'm going to show you for child psychiatry is mirrored there. So this is basically another rendition of the numbers you just saw, but these are specific to child psychiatry. This comes from the Child Mind Institute. Half of those estimated have a diagnosable illness. 22% of kids who have mental illness with severe impairments are having them before they're 18, and only this number are having mental health visits in any given year. These should be sobering numbers for us, that the people who need help are not getting them. These are disparities in terms of mental health service use, and if you look at various socioeconomic factors, these are not going to surprise anyone here. These fall along the lines that we would expect. Those who are most vulnerable tend to get the least care, and it is almost across the board. The gaps are far more significant in some areas. Like if you look over here, the odds ratios are worse on substance use just because we don't have any substance use care. So it gets, the picture is bleak. Substance misuse disparities here by race and ethnicity. And again, you can see the numbers. This is alcohol or drugs. This is alcohol and drugs, marijuana and opioids. And look, the timeline for this is actually some time ago. These have all gotten worse. This was in 2011. We don't have many of these studies that come out in terms of population. The group at Duke did this as part of the Clinical Trials Network, which I am now included in, and we can talk about that later. This is the child psychiatry workforce. Practicing child and adolescent psychiatrists, estimated number needed today, and this is our estimated current supply. So we are barely growing the workforce that we need. And this is after 30 years of investments in workforce development. I mean, we've been pumping money into these systems over and over again, right? And we don't get very far. This is what people in our field in child psychiatry start talking about, that we need to have a new pathway, a 4-year board certification for child and adolescent psychiatry. Minimum now 5 years to make a child and adolescent psychiatrist, so we lop off a year. I don't know about you, I don't think that that's going to make a huge difference in the pipeline here. Then I did my own little numbers on this. So this is the child psychiatry, assuming those numbers that we saw before are true. This is if we add in the nurse practitioners who are working in our field. I'm fortunate to work at a place that actually has a robust College of Nursing and a great mental health psychiatry nursing training program. And I have some of the best clinicians coming out of that program working for me. But that's where we need to get to. That upper line, we're never going to reach it with our workforce development. And I have to say that the nursing fields are growing their programs faster than ours, and more effectively in terms of growth, but we're still not going to reach the numbers we need. That's the take-home message. Does anybody here dispute that truism that I'm stating? All right, good. So people talk about this in child psychiatry that we need a different approach, that primary care should be a place that we could do this with a collaborative care. My points are these: that primary care doesn't have time to do a lot of new screens. Is Jessica here? I was going to ask her if she's having remarkable progress in terms of getting primary care to do these things. They are functionally doing this now. Primary care is dealing with the mental health crisis in their offices right now already. So asking them to do more seems to me to be a little bit of a challenge when they are being compressed by not only our ask and the patients coming in with all these issues, but then on top of that, you're putting all of the meaningful use outcomes on top of them, right? You got to screen for diabetes, you got to make sure they're growing, you got to make sure their hypertension's under control. And here I'm talking about populations at large. And I don't think, at least in child mental health, that these disparities are going to get closed in the primary care doctor's office exclusively, right? That's one solution, but it isn't going to close the gap 100%. So mental health issues over the entire population, adults, children, geriatric, are common. Access to evidence-based care is limited. Health disparities amplify these limits for underserved minority populations in the US. The mental health workforce is inadequate to meet the needs that presently exist. Everybody with me? Anybody want to challenge any one of these points? Please do. This is your chance to voice up and say that I have it wrong. All right. Even if we achieve the workforce goals, the health disparities will still limit access for underserved populations. So even in an ideal situation where we kind of achieve those numbers that I showed up there, I still think we're going to have disparities in our system, and we're still not going to be treating everyone equitably. Yes, a challenge. This is good. Very true, yes. A very true statement. So just because we increase our providers or our workforce doesn't necessarily mean that we are increasing access to evidence-based care. An excellent point. I fully agree. The next version of this, I will add a point B onto that to emphasize that, so thank you. All right, so where does that get us? What are the options that we have? Let's go through those really briefly. And here I really do want to have some questions, challenges, input from you. So number one, improve payment. If we paid people more, would we address this issue? Would this solve our problems? Tom, you're sitting right in front of me. I'm going to put the question to you.
I'm not sure it's going to grow the workforce
right.
in a needed way.
I mean, part of the rationale around improved payment is that, if we paid people more, people might be drawn into the profession more. People might be willing to, do more in this profession. I actually think improved payment might antithetically actually work in the opposite direction, because right now we're running probably very ineffective high volume practices, right? We sort of churn people through. If you paid people more, they wouldn't need to churn people through. You'd probably spend more time actually with people to provide higher quality care, but you won't necessarily address the numbers issue, and you won't necessarily increase the pipeline dramatically. Expanded insurance. So if we gave Medicare to all, hypothetically, since we're in the middle of campaign season, today is Super Tuesday, we did a big expansion of Medicaid. Did we address the mental health gaps in our system dramatically with that move? No. I mean, it was a good thing. I don't want to actually minimize that expansion. Expansion of Medicaid in our state, in Illinois, dramatic effect. I mean, people who otherwise were not getting care were getting care now, at least in some minimal form. That actually, counter to what people thought, we ended up with more ER visits rather than less, because that's the most accessible point. People were not coming into the mental health system because we had 6-month wait lists in our clinics before then, right? It wasn't like there was some miraculous new capacity that came with improved insurance, right? So insurance is, I think, a basic necessity. I'm not going to argue with anyone about that, but I don't think it solves our capacity and workforce issues in the mental health field. All right, those issues will still exist. Collaborative integrative care. I talked a little bit about this earlier. So if we worked with primary care more, would this solve? I mean, I argued this point earlier, but can anybody see a scenario where this really addresses the global issues here?
It might be incremental.
Okay. So again, worthwhile because look, these patients are coming there already, right? So my sister is a family doctor outside of Philadelphia. I talk to her all the time. I mean, thankfully her husband's a psychiatrist too, so she just calls him usually. But for child issues, she'll call me. And she's doing a lot of care of anxiety, depression, ADHD, and I have to say, my colleagues in family medicine, more than our colleagues in pediatrics are very nervous about doing any kind of medication work. The family docs, they're treating adults all the time. They're writing, Prozac and sertraline like candy. So they're pretty comfortable doing that with kids if they know that they're reasonably in the right space around this, right? But it's still not what we would consider to be what was argued earlier, evidence-based care, right? They're following an algorithm as best they can within the time limits that they have, but they're not providing the full range of care that people need. Co-location. One of my colleagues at Rush, kind of posited to me that this was the solution. All we had to do was start to co-locate our clinics and put them next to each other, and then we'd be able to do this. That's, from my vantage point, that's just moving kind of the deck chairs around on the Titanic, right? You're just shifting them to the other side in the hopes that, just that will reduce it. Now, that may increase referrals, that may increase better connection to care. We lose half of the people that are referred out of primary care just because people don't show up. Now, I think there's lots of structural challenges to showing up. And maybe co-location might address some of them, but again, it probably is incremental. So that brings me to my area. We're finally kind of like 20 minutes into the point of this, right? I think that we have to start to think about pragmatic solutions, and I think we have to think outside of the professional workforce. Because unless we have a solution that is highly scalable and can address people in multiple ways, we're not going to actually address that gap. So I'm going to posit to you that this is not the panacea. This is not going to solve everything. But this could address a significant chunk of our problem that then, if we did the things that are above this, maybe together all these solutions start to close this gap. So let's go from here to a little bit of what is out there in terms of lay people and protocol. So I'll start with the unified protocol. Unified protocol is not really a layperson intervention, okay? So this is David Barlow's work. Do folks know? Our psychology colleagues in here must know David Barlow, yeah. Lovely man, okay? So what I've done actually, my solution to doing this work is to invite all these people to do grand rounds at my institution, so I get to spend time with them and then learn from them. So he's been working on this. Now his contention is that, and this is the key point to take away, I think, from his work. He has argued that, first of all, we have all these disease and disorder specific cognitive treatments and psychotherapies. How many psychotherapies can you learn well with fidelity? Somebody give me a number. How many psychotherapies do you think you really know and can do with great fidelity? Zero. Okay, an honest answer here. Zero. How about one of our psychologists? How many do you do? Oh. Well, okay. We'll leave the neuropsychologists alone. 3. Tricia says 3. 2. That seems reasonable, right? I would say, can you learn more than 6 at best? Like if you were really a scholar of psychotherapies, right, you could maybe get 4 or 5 under your belt, right? And that's in the course of your professional career, right? So how many disorders do we have? How many treatments do we have out there? It's a spiraling number, right? So to think that we can actually, with scale, put these therapies out there is a little bit silly, right? If no one can use these treatments, if you require extensive training to do all of these, we're not going to get there. So Barlow's solution is actually, I think, very innovative. Let's find what are the common elements of this, the core elements around CBT, make a single protocol that is agnostic to the condition in front of you. So the person's going to come in, doesn't matter if they have anxiety, depression, even PTSD, even alcohol use, you're going to just launch into the unified protocol first. This becomes the entry point. Now, it doesn't minimize the value of those other therapies, okay? Those specialty therapies might still have a place in our system. It just says that this should be the front door for most people. And this then becomes the protocol that you teach all of our therapists to do with great fidelity. So you have one pathway to begin with, and then you differentiate after that if you don't have a response or if you have residual symptoms or there's things remaining. Everybody on there? And there's a whole list. He has a lovely list of publications now that are coming out. They're doing trials. They're showing impact in most of their trials that are as good as the specialty treatments, right? So that should give us heart that there's actually something in this that's actually worth pursuing. All right, so this is actually where I think our training program should start to go. In particular, our psychiatry training program should be there because we have mandated in psychiatry that you learn 6 therapies. This is what ACGME at least used to say. Cheryl, is that still true? Yeah. I don't know. I barely learned 1 or 2 when I was in training, and I probably wasn't very good at them. But if we train everybody in the unified protocol, we'd probably train our providers to have some degree of skill with it. And then I think the psychologists should be learning unified protocol and then learning 1 or 2 additional specialty ones in their areas of expertise. Because honestly, they do more of this than we do, right? And the same is probably true of other professions like social work and counseling. Same thing. Everyone should learn this one, and we'll give David a little more time to kind of get the data together, but it's gonna, I think, go that way. Second, common elements treatment approach. So this is Laura Murray's work from Hopkins. Now, Laura is actually an incredible speaker. If you haven't had her here for Grand Rounds, I highly endorse bringing her in. She's also an amazing trainer, and she is training our team. She's done 1 cycle of training with us on CETA, and she's doing another one later this month with us. So she's had multiple R01s from NIH to work on CETA, has done international trials in very low resource settings. So I've listed here Ukraine, Colombia, Iraq, Thailand. And the amazing thing about CETA is that she has been able to train people who have little or no educational background or skills to do this treatment with fidelity, and they've shown broad impact on anxiety, depression, PTSD, and substance misuse. The papers are coming out. I've listed a couple on here, but if you look up her work, you'll find them quite easily. So this is actually sort of the same philosophy in some ways as Barlow, but because again, she took core elements of cognitive behavioral therapy and really just package them in a way that people with very little education or background in therapy could do. It is not meant as a panacea again. There are cases that rise beyond this that require more specialty care. But as a frontline intervention, this works. And the fact that it works in diverse settings with different populations and different cultural populations is key. And it is a good framework to start from. Now, to date, no one has done a CETA trial in the US. So that's what we're going to try and do in Chicago, because Chicago is a low resource setting. The other one I want to mention is Friendship Bench. So this is Dixon Chibanda in Zimbabwe. Basically, he trained grandmothers in remote villages to do a manualized CBT for depression. The rationale was he was one of 12 psychiatrists. He has a lovely TED Talk actually online that you can pull up on YouTube. And I have to credit at this point, I have to credit my mother for pointing out Dixon Chibanda to me, because she watches all these TED Talks and kind of sends me an email one day and says, "You better watch this guy." And I did, and it was very relevant. I told her, I was like, thank you. So he has a nice paper in JAMA where they measured PHQ-9 scores, and the effect size on this intervention is about 0.3. Look, those of us that are heavy interventionists are going to say, well, we want at least 0.6, 0.7, come on, But 0.3 for a community intervention with grandmothers, I'm going to take it, Some effect is better than no effect in this game. And even if you're treating some proportion of the folks, it's okay. It doesn't have to be perfect, because that's why you're going to have the professionals still in the mix. This, what I'm imagining, doesn't get rid of professionals. It's actually just positioning them in a different place. Trisha and I met with Jürgen Unitzer from Seattle, and he had told us about Friendship Bench, that there was a trial that was done in New York that failed, right? And his contention was that it was because that the lay people were overwhelmed by the acuity of the cases that were coming at them. So in some ways, a lot of these layperson interventions, we need to, I think about the right population of patients. This is not for everyone, right? This is for a subset of patients that are in there. So my team and I kind of wrote up a little bit of a review paper for Psychiatric Annals on some of these cognitive behavioral therapies to address this, and focusing on mental health disparities. It's a very brief review if you wanted to kind of take a look at it. So with these ideas, I came to this, to UCLA, and pondering these things. And then 2 weeks ago, I put the STAR workshop to work. Some of the folks who are in here were at that workshop. You can see their products here. I preserved all of them in actually high resolution ones, so you can't see all the details on here, but I actually can. And basically, these are the summary points from that workshop as we were thinking about how do we take this forward. Number one, the group at the STAR workshop came up with the idea that they wanted broad skills. They felt that the lay people should have some degree of ability to promote resilience, encourage self-care, address frustration tolerance, and also address acute issues. So what happens when you're a lay person and you're working with someone and they come in with suicidal ideation, right? We need to have a framework for dealing with that. They actually came up with a lot of the typical settings that one would expect where you could deploy this type of intervention, perhaps. Schools, churches, work, the virtual space was considered in that. Interestingly, they were very imaginative in this workshop. They came with some atypical things. The DMV. And people are waiting around at the DMV a lot. There's probably a lot of frustration at the DMV. You could probably use it as a place to practice some frustration skills if you just had people hanging out there. Uber, Lyft drivers, I don't know. I mean, I've taken a lot of Lyft rides here in LA since I've been here. I think some are better than others, but maybe there's a subset of them that could do that, especially if they're doing longer journeys with people. You could work at homes. This is part of what we're doing in Chicago, is working on a street block basis with folks, parks and recreation district folks. We personally have had some interactions in Oak Park, which is a suburb of Chicago, in their library, and work with the folks there. And I know that the COE team here is doing some work with the librarians here in LA. They made the point that community engagement is critical, that you have to have constant and recurring feedback as you're working through this. You can't just take one of these models and pop it down in the middle of a community and expect it to take hold. It has to be done in tandem with the community and very much in partnership. So that brings me to this, some of the basic principles. And I want to kind of go through these in a little bit of detail with you. The first, I think that screening and assessment of individuals is really important on the front end. And one of the things that I've been most impressed with as we've worked with Focus is the check-in. The idea that you do an assessment using validated tools on the front end. So I can imagine with the layperson intervention that we would have a tool built into their smartphones, right? I mean, everybody carries these phones with them. We can make sure that all of our lay people have a device with them. And that device should have screening tools in them. And, you could project easily. Like if you wanted to kind of get the big three, at least in Chicago for us, right? You do the PHQ-9 to get depression, you do the PCL5 to get PTSD, and you do the audit to get alcohol. Now, I don't want to minimize the other drugs, opioids, cannabis, all those things. Turns out if you get alcohol, you probably get all of them as well. The overlapping use patterns of folks who have substance use is so high that for the most part, I mean, cannabis is a little bit of an exception. There are a fair portion of folks who just exclusively use cannabis and don't use other drugs. But when it comes to alcohol and opioids, you know, those drugs tend to overlap. People who use meth often are using alcohol as well. So you don't have to actually ask about those specifics. You can probably just screen alcohol and get most everyone, right? So if you had that in there, you would get results in real time. And we do this in our hospital right now for substance use. We screen everybody that comes in with a 2-question pre-screen that nursing asks as they're being admitted. Do you use alcohol? Do you use any drugs or, you know, prescription medications, but not for, you know, prescribed reasons? And then if they answer yes to those questions, then they get the audit or the DAST. And there's a whole structured approach to this that we use based on the score on the tool. So the tool actually then guides the intervention, right? And I think one of the things in the check-in that I like is that you give graphical information to the user, you know, to the family in that case with focus that, you know, shows them where they are in the population. And you could do this both for the therapist in this to kind of have an idea of who they're dealing with, but also for the person who's being evaluated with this tool and give them immediate feedback. This should then lead to the option to risk stratify patients. So one of the things that we know, I mean, the friendship bench trial in New York, you don't want the severe patients ending up in the layperson's hands, right? The people with really extreme PTSD, severe depression, suicidality, severe alcohol or substance use, it's not appropriate probably for them to be handling those cases. What you want them to do is actually take the mild to moderate cases. Now, all of you are probably feeling a little bit of anxiety about that. You're like, wait, you're gonna take away my easy cases. So I'm gonna sit there in my clinic and I'm just gonna have the train wrecks come in. But if we do this right, I mean, first of all, you probably shouldn't be seeing the easy cases. I mean, one of the things I keep telling the pediatricians who refer me cases that, you know, garden variety ADHD, I shouldn't be seeing them. I am probably a little bit overqualified to treat ADHD, you know, that's garden variety. I should see the one that has failed 2 stimulant trials, right? That's a fair case to send to me. But if you're sending me that case, then I'm not taking care of the more complicated cases, right? And what's happened is our schedules have become compressed as behavioral health providers because there's such a high volume of some of those routine things coming through, right? We have kind of scheduled according to that. So we're not actually giving our folks, the people in here, we're not giving you enough time to actually deal with complex issues. And then when you do get that person who has a lot of issues coming in, you're sitting there, you're like, wait a minute, I got like 45 minutes to deal with this and I have no idea how I'm gonna do this, right? And then your whole afternoon basically is gone, right? Fair assessment? Yeah, Tom's shaking his head. He knows clinic schedules here well, right? So ideally, if this layperson and peer intervention works, right, the low-end stuff actually stays out of our primary system and out of our pipelines. And then we can say to all of you, you know what, we need to build your schedule so you have more time to deal with complexity. You're gonna have the comorbid, you know, the anorexic who also has ADHD and is abusing their stimulants. That's the case that you need to be taken care of because, sorry, the peer can't do it, the primary care can't do it. You're the only ones who really have the skill to deal with that scenario. So risk stratifying patients is essential because we need to get the right patients into this care level. And the other patients need to be appropriately then referred to specialty clinics. And sorry, if there's somebody who is, you know, chronic schizophrenic out there, they need to be in a specialty clinic for care. They should not be cared for by the peer. So that also leads to this idea of referring to the right level of care at the right moment. So one of the things that we have faced in Chicago is that in our veteran program, for example, we have a lot of vets in Chicago. What happens is if any vet is having an emotional disturbance, they call one of two numbers. They either call the VA hotline or they call the Wounded Warrior Care, Wounded Warrior Projects hotline in Jacksonville. Those are the two major resources right now in the country. And the call center in Jacksonville, which I've seen, just keeps growing larger and larger because they just get more and more calls, right? Now, it doesn't matter whether you actually are a suicidal case or whether you are someone who's had, low-level insomnia symptoms that are probably driven by PTSD for 6 months. They're all going into the same phone lines and the same channels. Does that make rational sense to anybody here? Wouldn't it be great if we could actually pick off the people who need care like right now? Like this person should not be left alone, right? They are at risk of hurting themselves. You should call 911. Don't even bother calling Jacksonville. Why are you calling Jacksonville for that person, right? So the screening and assessment tool should allow us to help make that decision. It's not going to be right 100% of the time. You're going to end up with people going down the wrong channel at times, right? But if you reduce the number of calls that are going in inappropriately to different systems, you can potentially get this. And this is really a precision medicine principle, right? Trying to get people to the right level of care at the right moment. Does this person need to be seen this week? Or can they be seen in 2 weeks? Or can they be seen in a month, right? We could actually help use the assessment tools that we have to put those risk stratifications in place and make those decisions wisely and help the peer to make that choice with the individual who's suffering. Because sometimes the people who are suffering don't even know what the right level of care is. But all of you do, and to the extent that we can put the rules that you're generally using, which are not, I think, that difficult to put into some type of framework, into this, then we can drive this forward. So this goes back to this principle that only mild to moderate sort of participants should be in this late treatment. Let's not give them the extreme cases. Even though there is rationales, like from the substance abuse space, we see peer recovery support specialists who provide a lot of collateral support to individuals with severe illness. But that's when they're engaged in professional care, right? It's not absent that. And again, we don't want to overwhelm the peers that they don't want to do this anymore. They want to feel like they actually have the capability of addressing this. We have to provide backup for more severe cases. This is critical, and this is where the professionals come in. This is you and I and everybody in this room who treats cases have to be part of this system. So one of my asks to my hospital is that I wanted to build a telehealth team first before we deployed our community intervention and our layperson intervention. And I'm fortunate that I had then had a dean and now I have a CEO, same person who's moved up, who's a psychiatrist. He actually said to me, no, don't do that. Don't build your own tele-mental health team for your community program. He said, build me a tele-mental health team for the whole system. And that tele-mental health team will take care of your community program as well as taking care of all of our other needs. Because we have 1.5 million lives under our care in primary care at Rush. It's a lot of people, right? And there's a lot of mental health issues, and they're coming up everywhere in our primary care clinics, in our specialty clinics, in our ER. And so we don't have enough consultative services in our hospital to cover all of that, right? Like we would just be, and our clinics are scattered across the west side of Chicago, its suburbs, touching the rural areas on the outer rim. So we can't possibly staff that, right? So the telemental health team ends up being a virtual staffing of that. And actually, our community needs are probably relatively small. How often, when you're in the community, do you end up just happening to be on the block with somebody who is actively suicidal that you need to call and help with? It's not going to happen every day. It's probably not even going to happen every week. Look, I can tell you my experience when I was medical director of the Road Home program, which is our veterans program at Rush. We actually had a suicide protocol built in for our assessments because we launched these assessments out to folks, right? So we actually had to have a system, like if we got a positive PHQ-9 suicide question, we actually had an alert system for emailing like a dozen providers, and then 10 o'clock at night you're talking to that. That probably happened once a quarter that we would have one of those cases come up. And that's a high acuity population, right? I mean, we have severe PTSD in that population. We know in the veteran space there's a lot of suicidality. So if that's true in that population, it's going to be even rarer in a general community population with mental health issues. It'll come up, but not that frequently. But we need to have a plan for that. This telemental health team could also play this role. And I want to, Tom and Tess and the team out at the Veteran Family Resilience Center really kind of, brought this up, and I think it was a great point as I was discussing with them yesterday. We need to use that as a means to provide care and support for the lay providers. Some of them are going to have issues that they are contending with, and working with mental health cases is going to trigger some of those things. So we have to have a care system for the care providers, right? And all of us are beginning to learn that in our work here in hospitals and universities, right? We're only now beginning to think about burnout and self-care after years and years of, watching these obvious things happen, right? So caring for the carer has to be part of our system here. And all these things, I'm pointing these things out to you because we have to put these things all in place before we launch. You can't do this afterwards. Ongoing assessment. So repeat the evaluation that we did in the beginning. Look for impact, right? Is the person getting better or not? If the person isn't getting better, then our professional systems probably need to be there to pull them out, right? But if they are getting better, it's okay. Maybe they don't even have to come in. Maybe the layperson intervention is enough, right? So that's I think, the key elements behind this. Questions about those key elements? It's a lot there. Folks at the VA, I'm sorry, I have no way of getting your questions, but unless you tweet them at me. So, I don't know. Kumi, yes, nice to see you. Yeah, it's a great question. So where does technology come in? Could it be part of a standalone treatment? I mean, I see it, at least in this rendition, I see it as part of the assessment. I would like us to actually build the manuals or the guides that the layperson's going to follow into the tool so they all naturally flow, right? The repeat assessment, all of that can be designed into one workflow. Could we actually have tools that are standalone that people get referred to? Sure. I mean, right now we have this, sea of apps out there of questionable value, right? And there are various attempts like CyberGuide and others that are trying to bring some degree of order to that universe. I mean, honestly, engagement's really low on apps. Half of the apps that get downloaded never get opened in the health space, and even fewer of those that are open are used more than once or twice, right? So it's very hard. I think, this is an open question. It's an open field. Right now, various people in that space are starting to try to rethink this and really trying to bring sort of a perspective for designing engaging games. Like if we could make our mental health apps as engaging as Angry Birds, winner, right? If we could do that, we would actually get people to use it, right? Or, you pick your most addictive game. But I don't think we're yet at the point where we actually can wed that to a therapeutic objective. But that being said, there are some apps out there that actually have great content in them and are really well designed. I think some of the mindfulness apps are actually amongst the most used in the space out there and are likely to be a good genesis point in this, right? Those are things that people can easily access. Other ones that are good, the VA has some excellent ones. The CBTI, I have to say the insomnia one that the VA has produced, an excellent app, right? And It's not that hard to follow the instructions there. So as we develop new ones, hopefully we'll start to get more engagement then in that space. Yes? So the question is, just repeating it for the folks on the video, why focus on lay people when we have master's level clinicians who may need these same tools and these same skills? I won't argue that point and say, yes, these principles could generally be used by almost anyone. But I would say to you, my response is twofold. One, I think that we have the master's level clinicians out there already, right? And even though many of them may not be following evidence-based practices, and many of my colleagues who are psychiatrists don't follow evidence-based practices. So this is across the professional fields. I don't know that just adhering to evidence-based practices is actually going to address that gap I discussed earlier, right? So I think we need an additional workforce, right? And I think the advantage in using a layperson model is that the layperson model ends up being one that is much easier to embed in communities that are marginalized and vulnerable and don't have access to care right now. So one of the most telling things that really, when I was starting down this road, was when we met with some of our partners in Chicago who are, organizations from the West Side. And I kind of described a very early version of this to them, of this vision. And several of the leaders from those organizations actually said to me, you know what, this sounds like a good idea to us because we're tired of people, who don't look like us coming in and sort of dropping into our neighborhoods and telling us what we should do. And they said, we really like this idea of actually building capacity amongst our own community. And so I think that's the advantage here, because if you look at the professional fields, even master's level clinicians, they skew. They skew towards, higher income, they skew white, they skew, in various ways. They don't look like the communities that I am most concerned about. And one of the things that I hope comes out of this is that if you get enough lay people to do some of this work, and you don't have to do it full time. This could be, done on a part-time basis. This could be done in various different formats. Some of those individuals might grow interested in this and want to follow a professional path. And so this becomes a pathway to maybe going to nursing or counseling or social work or medicine or psychology, right? And you can actually, I think, design the training so that it is a series of stackable educational options. And we have a great relationship with Malcolm X College in Chicago through an alignment through Rush, and we're sort of partnered with them. They're very close in terms of our geographic space. And they're basically the entry point for a lot of people to come into this. So that's another way to get resources back into the community if people follow a professional route. Norita. Yeah. It's a great question. So Noreen is asking a critical question that it sounds like deja vu, because this is very similar in some ways to the community mental health movement. I mean, I think the lesson from the community mental health movement is we moved too quickly, too far, from that movement from the deinstitutionalization into the community mental health space, right? The idea was that these medications were going to free people from the institutional structures. And I think it's pretty obvious now, there are some patients who were actually better served by those long-term care institutions that were humane institutions, because right now, I can tell you, they're all ending up in our prison system. That is our new de facto mental health long-term institutionalization system, right? And I say this as someone who, when I was here in California at Stanford, had people admitted to Napa State Hospital with much regret, but that was the only place you could send them, right? So I think the lesson I take from that is not to move wholesale in any one direction, right? There is no single solution to the issues around this. It has to be an array of tools and solutions. So I think we are moving to a point, I mean, at least in Chicago, we're on the unfortunate avant-garde of having our community mental health system taken apart because our city and our state are broke. So they literally are closing those community clinics. This becomes a version of that, perhaps, that uses these digital tools and this virtual space to engender the same result in some ways. I agree with you. The principles are very much the same. But we may be able to regenesis that system that we have lost locally by using this other space that is being created now. And if we use it smartly and effectively, we might be able to advance it a little further than where we were before. Yeah.
I was going to add that before we didn't have the technology and data infrastructure to drive some of this continuous quality and risk stratification monitoring that would be possible now.
Yeah.
I mean, it just wasn't there before.
Thanks for the talk. I was just going to add a couple of points. I've been involved in a number of large rollouts with health workers in mental health, both here and in New Orleans. And one issue is when you increase the diversity of the population that the regular providers are seeing, right? Because one thing that happens when you have more lay health worker, more community engagement is the connection that regular providers have also diversifies. Mm-hmm. Then another basic principle is training, whether it's cultural competence training or community engagement training for the traditional provider team. It's kind of two-way. It's not just training the community health worker, it's the health worker helping with the community, making everyone ready for a broader base. So that was, I mean, we've just seen that repeatedly. Another point is even if you prioritize mild, moderate for people you can't control what happens, right? People get sick, obviously. So I think the supervision structure becomes very important, and suddenly it'll be medical illness instead of. So we've had to give a lot of thought to that, and have also used technology to help us with some of those issues. But and also, at least here in South Los Angeles, much higher rate than you're mentioning of serious suicidality from routine screening. So, for example, out of a sample of 1,200, 358 suicide interventions that we had to do by telephone in 18 months. So that's very different than once a month or once every 2 months or something like that. So it might, again, maybe some of that is as things roll out and people open up more and there's more engagement. So it might be also anticipating, we need a system that could handle higher volume. Anyway, just some points from our experience.
Those are all great and valid points. Yeah, and I think I very much am taking lessons from many other spaces, and yeah.
Last question, because we're almost out of time.
Okay.
Thank you for your talk. One thing that we've actually started here is delivering the unified protocol in the Child and Adolescent Mood Disorders Program, Center for the Assessment and Prevention of Prodromal States, as a way to provide these basic skills to a broad range of patients. And we've delivered it in a group format, actually, in part because of the limited access we had to providers, but also because we thought it would be a useful way of providing more care to more people. And I just wasn't sure, in terms of some of the things that you were talking about, if that is something that would be something that would fit into your model in terms of obviously providing more providers allows for more access or allows for more care, but if having a group format would fit into some of these models, or providing it in a school setting where social emotional learning is starting to be implemented?
Yeah, I don't see group models as being antithetical to this. I think I have, to this point, envisioned sort of single kind of touch points, one lay person working with one individual, just as a beginning point in this. I think management of groups is a skill set in and of itself that can be hard to master, but I think one can imagine scenarios, and there's certainly great examples of successful group and community-based interventions. I mean, I think the AANA structures. I mean, for all the criticism that people might put against that rubric, right? It's an incredibly successful group model, right? And it really is like self-perpetuating. It creates its own leadership and future leaders in that structure. So I think there's definitely room for that. And we've done some of our treatments, our evidence-based treatments with professionals in group settings and seen success. So our veteran program runs all of the CPT treatment with a group format and has seen good success with that. Although what's interesting is we're now doing, we have one of our psychologists who's doing 1 week CPT. So it's 2 sessions a day of CPT with an individual over 5 days. And he can just drive PTSD symptoms out, and at 6 months it's retained. So again, I think that's about the risk stratification. It's about which patients need what type of care, and maybe to some extent what their preference is. Some will want individual, some will want group. And I think we can probably start to create spaces for both, but with all the caveats that, that we need to make sure we have all those structures around them. So that's what I'm struggling to build now, is all the structures first before we actually go into this wholesale. We're kind of dipping our toes into it. Yeah.
Okay, we need to stop. I want to thank you so much.
Thank you for coming.